Hi, my name is Concomitant and you're watching the video Alphabet Patterns, Aetiology. In this video, we'll be discussing the various causes of alphabet patterns. We will focus on AV patterns specifically, and this will provide an overview. It will not be an exhaustive list of all etiologies of AV patterns. Okay, here we have a list of some of the common causes of AV patterns. We can have abnormalities of the extraocular muscles in terms of their action. Overactions or underactions can cause AV patterns. The configuration of the orbits have been associated with AV patterns. And then there are anatomical anomalies which can lead to AV patterns. We'll go through each of these. Let's start off with anomalies of the muscle actions, and let's start off with the anomalies of the vertical muscles. So if we have an over or under action of a vertical muscle, it will influence the deviation in direct elevation and depression. The reason it does this is because of the secondary action of the vertical muscles. So let's take, for instance, the inferior oblique, which works in elevation. The inferior oblique is also an abductor. So if the inferior oblique is overacting, when you move the patient into direct elevation, it may influence that position there dependent on how much of an overaction you have. And you can see an increase in abduction in upgaze, in which case if you had a ESO, for instance, in primary, the ESO would become smaller in upgaze due to the overaction of the inferior oblique. If, however, you have an underaction of the inferior oblique, the opposite will happen. What you'll have is a reduction of abduction, and the ESO could potentially become larger in upgaze, producing an A pattern. Here I have a list of cyclovertical muscle palsies and how you would explain a V pattern in these instances. Let's start off with a right superior oblique palsy. Now, here we expect a V-ESO, and an ESO because a right superior oblique would generally cause an esotropia in primary position. Now, here we have the muscle sequelae, which will explain the V pattern. Let's start off with the right superior oblique underaction. The right superior oblique is an abductor and works in downgaze. So our expectation is that we'll have a reduction in abduction in downgaze. So if we have an esotropia to begin with, we're expecting that a reduction in abduction is likely to give us a greater ESO in downgaze. Okay, its contralateral synergist is the left inferior rectus, and due to the muscle sequelae, we're expecting an overaction. Now, the inferior rectus is an adductor and it works in downgaze. So we're expecting an increase in adduction in downgaze. Now again, this will mean an increase in the ESO deviation in downgaze. So this pair here, the right superior oblique and the left inferior rectus, are contributing to the ESO becoming larger in downgaze. If we now move over to the right inferior oblique, the ipsilateral antagonist, this is likely to be overacting, in which case we'll have an increase in abduction in upgaze, and here we'll see a reduction in the ESO in upgaze. And the contralateral antagonist, the left superior rectus underaction, will cause a decrease in adduction in upgaze. Again, reducing the size of the ESO. So this pair here is contributing again to the V-ESO pattern. So depending on the extent of the right superior oblique palsy, dependent on the actions of these muscles, how underacting or how overacting they are, potentially we will see a V-ESO in this instance. Now the next example I've given you is a right superior rectus palsy. I'm not going to go through each of these examples. I've also given you on the next page a few more vertical muscle palsies. Again, I won't go through each of these examples, but they're there for you to gain an appreciation of how a palsy of the cyclovertical muscle will lead to an AV pattern. Here I've also given you a diagrammatic representation of the secondary actions of the extraocular muscles and how they lead to an A and B pattern by Garg and Alio. So in looking at this, what we can see is this is the right eye, this is the left eye, and what it's indicating is, as an example, this is the superior oblique or the right superior oblique. The superior oblique is an abductor, the inferior rectus is an adductor, and if you have an underaction of the superior oblique, an overaction of the inferior rectus, we're expecting that we'll see a V pattern. Now let's go through an example of a patient in 9 positions of gaze. You'll recall that in the last video regarding clinical investigation of patients with an AV pattern, I talked about utilising the ocular movements or assessing a patient in 9 positions of gaze as an opportunity to see if you can find a possible cause for the AV pattern. So here what we want to look for is any over or under actions of the cyclovertical muscles that may explain an A or V pattern. So let's start off with identifying what alphabet pattern this patient has. Okay, in primary position we can see an esotropia. And then when we take the patient into upgaze, there is a reduction in upgaze. And then when we take the patient into downgaze, there's an increase in the esotropia. So we have a V pattern and a V pattern ESO. Okay, let's now progress to assessing ocular movements as we would using the H pattern. Okay, so we'll start off with primary position and then we'll move over into right gaze. And what we can see here is that the left eye is starting to elevate. So we'll go over into upgaze and what do we see? We see an overaction of the left inferior oblique. If we now come into downgaze here, we can just see that there looks like there is an underaction of the superior oblique. This is a bit more difficult to see. A cover test and a PCT would be required in this position. Okay, let's move over now to left gaze. And we can clearly see again that the right eye is starting to elevate in this particular instance. So we'll move over into upgaze here. And what can we see here? We see an overaction of the inferior oblique of the right eye. And then if we move into downgaze here, what we can see is an underaction of the superior oblique of the right eye. So overall, in this particular instance, the VESO can be explained by an underaction of both superior obliques and an overaction of both inferior oblique muscles. Okay, one more example. Here we have a patient who clearly has an esotropia in primary position. The esotropia is larger in upgaze and smaller in downgaze. We have an AESO in this instance. We don't have all 9 positions of gaze in this particular instance, but what we can clearly see is in elevation in the tertiary positions here, we have an underaction of the inferior oblique. Both on left gaze and on right gaze, we can see a right inferior oblique underaction and a left inferior oblique underaction. The fact that there is an issue with elevation in adduction, both in right gaze and left gaze, will lead to an AESO pattern in this instance. Just to note that this actually isn't an inferior oblique palsy. We'll come back to what this is later down the track. So we've just discussed the most common cause for AV patterns. When you have an overaction or underaction of a cyclovertical muscle, it can lead to an AV pattern. Just to note that this does not apply only to neurogenic palsies. Recalling concomitant strabismus, we discussed that patients can have isolated cyclovertical muscle over underactions. In particular, we usually see inferior oblique overactions. Remember, in infantile esotropia, we often see inferior oblique overactions with these patients. I've seen a number of patients with divergence excess exotropia with inferior oblique overactions. So in this instance, an isolated muscle which is overacting can in and of itself cause an A or V pattern. In the example I just gave you with the divergence excess XT, we'd have an exotropia in primary position. As the patient elevated, if the inferior oblique overaction is significant, we will see a further abduction in up gaze, and the exotropia will be larger in this particular position of gaze. And I would record that patient as having a VXO. So just a reminder that it doesn't only apply to neurogenic palsies. If you have a concomitant strabismus with cyclovertical muscle action anomalies, then you can expect to also see AV patterns in these patients. Now, it's also thought that horizontal muscle action, so an overaction or an underaction of the medial lateral rectus, could result in an AV pattern. Now, this is not as well supported by the evidence, and Urist in 1958 was the first to indicate that an over or underaction of the medial rectus can cause an AV pattern. The theory goes that the medial rectus acts more effectively in down gaze as compared to the lateral rectus more effectively in up gaze. If you think about ocular movements, when we're looking into down gaze, we have more convergence. We're obviously utilising the medial rectus more. So as you elevate or as you move more into up gaze, you're going to be using those lateral recti a little bit more. So the theory goes that if this is the case, then if you have an over or under action of these muscles, it could influence the AV pattern in up or down gaze. As an example, let's say a patient has an esotropia in prime position and the medial rectus is overacting. So in this instance, what we expect is that as the patient moves into down gaze, the medial rectus, which is an adductor, it's overacting, the ESO will be larger, and we'll see a VESO in this particular instance. Now here I've given you a diagrammatic representation of how a overaction or underaction of the horizontal muscles can lead to a ALV pattern. So as an example, here if we have an overacting medial rectus, depicted here by these lines here representing the medial rectus and an overaction, what we should see is a VESO. Now there are a couple of typos in this particular diagram. This here should be an underacting medial rectus as depicted by the arrows, and an underacting medial rectus will cause often an AXO. And over here, this should be an overacting lateral rectus, not an LT, which represents an increase in abduction. And here are those corrections. Okay, earlier I mentioned that orbital configurations can be associated with AV patterns. Specifically, mongoloid and anti-mongoloid features have been associated with AV patterns. Mongoloid and anti-mongoloid features relate to the palpable fissures, and mongoloid means an upward slanting and anti-mongoloid meaning a downward slanting palpable fissure. So if we have a look here to the right at the individual, in this particular instance, they've got anti-mongoloid facial features. And you can see here, if you take a look at the palpable fissures, they are downward slanting. Okay, these are often associated with a VESO or an AXO, and mongoloid features are often associated with AESOs and VXOs. And here I've actually given to you that in a mongoloid patient, an ET is often associated with an inferior oblique underaction, which is what results in the AESO. And often their XTs have inferior oblique overactions where we see a VXO. Again, if we come back to the patient with the anti-mongoloid features to the right here, we have a look at this patient in prime position, they actually look relatively straight, but once we move over into right gaze, we can see elevation of the left eye and clearly here an inferior oblique overaction, not much in down gaze. If we move over to left gaze, we can see again an elevation of the right eye in this instance, an inferior oblique overaction here, and it's hard to say if anything is happening there in down gaze. In terms of the eyes, it's difficult to see down gaze because the eyes are embedded, or they've gone a little bit too far in down gaze to be able to see what's happening in down gaze. The patient does have a V pattern and an esotropia in this position, which we can't see in the photograph. So this is an example of a patient with anti-mongoloid features who has an ET and an overaction of the inferior oblique causing a V esotropia. Now let's move on to anatomical anomalies. If we have extraocular muscles inserting on the globe in an anomalous position, it can be expected that the action of that muscle will alter. If we look at the obliques, Gobin in 1968 indicated that If the obliques insert closer or further away from the anterior-posterior axis, then we can expect changes in its action. Let's take a look over here to the right at the superior oblique. This is the normal insertion of the superior oblique. So this is where the trochlear should be, and the superior oblique should be coming in and inserting on the globe at around 51 degrees. However, if the trochlear is displaced forwards, what we will see is that the superior oblique will come in at a more acute angle. Now this is sagittalization of the oblique muscle. Sagittalization is when the muscle is closer to the anterior-posterior axis of the globe versus desagittalization, which is when it's further away. And what we expect with sagittalization is that we're going to see an increase in the vertical and horizontal action and a decrease in the torsional action. And when we have desagittalization, we'll see the opposite. And what we're interested here in relation to AV pattern is what happens to that horizontal action. If we have an increase in the horizontal action of the superior oblique because of the angle at which it now inserts into the globe, we can expect that because it's an abductor, it'll increase in its abduction effect. So in depression, we're going to have an increase in abduction. So here I give you an example of the sagittalization of the superior oblique or the inferior oblique and what we would expect to see in terms of an A or V pattern. I've also given you here a diagram of desagittalization. And so what we can see here is that this is the normal position of the trochlear and the normal insertion of the superior oblique. However, if the trochlear is moved forward, we're going to have a more acute angle insertion, in which case we have sagittalization, and if it's further back, the insertion will be back here and we'll have desagittalization. We can also have an issue with the insertion of the horizontal muscles, the medial rectus and the lateral rectus. And here, if the insertion is higher or lower than the normal position, what we will see is that abduction or adduction, depending on whether we are talking about the lateral rectus or the medial rectus, will be increased in down gaze or up gaze. Now, the rule of thumb is that if you've displaced a horizontal rectus muscle vertically, so up or down, it will weaken its action in that direction. So if, for instance, the medial rectus is displaced upwards, the adduction will be weakened upwards. However, it will be strengthened in the opposite position. So when the patient looks downwards, that medial rectus will have more of an adduction effect, or you'll get more adduction than usual in down gaze. So here in the next slide, what I've given you is an example of a lateral rectus horizontal insertion anomaly. And here we see that if the lateral rectus is high, we will favour abduction in the opposite direction, which is depression, and we'll have a weakening of abduction in elevation, which results in an A pattern. In the next example here, I've given you a low insertion, which will favour abduction in elevation, and we'll see a V pattern. In the coronal CT scan here to the right, that is in the von Norden and Campos textbook, we can see that the lateral rectus here, and these are the lateral rectus here, we have a displacement of both these lateral rectus downwards. So in this instance, we have a low insertion and the patient presents with a V pattern clinically. Another anatomical anomaly that can occur is that there can be displacement of the muscle pulley, in which case the action of the muscle may alter. If you remember, the muscle pulley is the mechanical origin of the extraocular muscle. So a displacement of this pulley will actually cause an A or V pattern. If we take a look at the examples below here, here we have a displacement of the lateral rectus down and the medial rectus up. And again here, medial rectus up, lateral rectus down displacement, in which case we would see a V pattern. And in this particular instance here, there's upward displacement of the lateral recti and downward displacement of the medial recti, which would give us an A pattern. This type of displacement of muscle pulleys is often associated with mongoloid and anti-mongoloid features. So we can see that if a muscle inserts in an anomalous position, if we've got muscle pulleys that are displaced, we will have anomalous eye movements. And the other cause for anomalous eye movements is excyclorotation of the globe. When a globe is excyclorotated, then what we can see is that the plane of the action of the vertical and horizontal rectus muscles will change. So if we take a look here, this is the superior rectus, medial, lateral and inferior rectus, and the action of the superior rectus elevation and inferior rectus depression, medial rectus adduction and lateral rectus abduction. So where we have an excyclorotated globe, as we have here to the right, what you now see is that the actions of the vertical and the horizontal rectus muscles will now change because of the excyclorotation of the globe. Now below here you'll see that I've indicated this is often associated with patients with craniofacial disorders. So we're not specifically talking about patients with neurogenic palsies who have an excyclotropia. This often occurs in patients with craniofacial disorders. They actually don't have a neurogenic palsy, but they have excyclorotated globes. This generally produces a V pattern. And we can see this a little bit more clearly in the images by Guyton and Wingarden. Here we can see that the displacement of the superior rectus in this image and here is causing abduction in elevation. So the excyclotorsion is causing this displacement of the superior rectus with abduction in upgaze. And in downgaze here, the inferior rectus is causing adduction or greater adduction in downgaze, producing what appears to be a V pattern. Looking at the horizontal muscles here, we can see the downward displacement of the lateral rectus and the upward displacement of the medial rectus is causing what appears to be an upshoot of the eye in adduction. And here again, this upward displacement of the medial rectus, downward displacement of the lateral rectus is causing what will appear to be an upshoot in adduction. What this will look like is like an inferior oblique overaction. And on assessing the patient in the clinic, your observations will be such that on ocular movements you will be recording IO+. However, you'll later realise that it isn't the inferior oblique overaction that's causing the elevation in adduction, but rather it is excyclorotated globes. You're not likely to work this out until you look at the fundus and discover that there is excyclorotated globes. Often, if you have a patient who's presented to you with a condition such as craniosynostosis, which is a craniofacial condition, you will be questioning from the outset whether what you're seeing as an inferior oblique overaction is truly an inferior oblique overaction or whether you have excyclorotated globes. So a presentation for an assessment of motility of a patient with craniofacial features should immediately put questions in your mind about whether you have excyclorotated globes if you see those inferior oblique overactions. Here we have a patient who appears to have inferior oblique overactions. If we have a look here, this patient is in dextroversion and we can see that the left eye is beginning to elevate in this position. If we took him over into dextroelevation, we would end up recording this as a left inferior oblique overaction. If we have a look at the patient in left gaze, again we can see that the right eye is beginning to elevate. And again, if we took the patient into lavo elevation, we would end up recording this as a right inferior oblique overaction. But when we have a look at the globes, we can actually see that both of these globes are excyclorotated. So in this particular instance, while we would end up potentially recording in the history that there are inferior oblique overactions, the inferior obliques actually are acting normally. The reason that we have what appears to be an inferior oblique overaction is due to the excyclorotation of the globes and therefore the displacement of the extraocular muscles. Another reason as to why a globe may be excyclorotated is due to sensory torsion. Now, sensory torsion is a term coined by Guyton and Wingarden, and they suggested that the globe can excyclorotate or intort where there is a loss of fusion. Now you'll recall in concomitant strabismus we talked about sensory or secondary exotropies and esotropies that are caused by loss of visual acuity. Now what Guyton and Wingardin are suggesting is that when you lose fusion, then not only can the eye become exotropic or esotropic, but it can become excylorotropic or incyclotropic. So should this happen, what you will end up having is again the rotation of the planes of action of the rectus muscles. And this will lead to the appearance of an AV pattern, just as we saw a moment ago in the photograph with the girl. Lastly, mechanical limitations can lead to alphabet patterns. Now, these are generally demonstrated once the limitation of movement is reached. So in neurogenic palsies, for instance, the AV pattern is relatively gradual as you assess the patient up and down gaze. However, with mechanical limitations, they may be fairly abrupt in presentation and may occur only in extreme positions of gaze. We'll come back to AV patterns related to mechanical limitations as we look at specific conditions that are mechanical in nature. So in summary, there are a number of causes of A and V patterns. The most common cause of an AV pattern is an over or under action of the cyclovertical muscles. So generally speaking, in most instances, you will be able to identify the cause of the A or V pattern during ocular movement assessments when you detect a cyclovertical muscle under or over action. Okay, however, there are a number of other reasons why an AV pattern may occur. As we've seen, they can be associated with mongoloid and antimongoloid facial features where we may see an over-under action of cyclovertical muscles, or there may be a displacement of pulleys, for instance. We know that anomalies of the muscle insertions can cause AV patterns such as sagittalization or desagittalization of the oblique muscles. Any anomalies of the muscle pulley, such as a displacement of the muscle pulley, will cause a change in the action of the extraocular muscle, and we may see AV patterns. If we have an excyclorotated globe, this can also give off the appearance of an AV pattern, and usually they will cause what looks like inferior oblique overactions, but indeed it's simply an over-elevation of the eye in adduction that is being caused by the excyclorotation of the globe. And remember, we're not necessarily talking about neurogenic palsies here. If you think about a superior oblique palsy will cause an excyclotropia, but in a superior oblique palsy, we actually have a muscle sequelae over and under actions of the cyclovertical muscles, which are causing a V pattern. So in this instance, we're more talking about patients who have a condition that leads to an excyclorotated globe that's not related to a neurogenic palsy. And this generally happens in craniofacial patients, which are patients such as those who have craniosynostosis. Okay, and lastly, mechanical limitations can be associated with an A or V pattern. Okay, that brings us to the conclusion of this video. Thank you for watching.